and I want to thank you, the community, for inviting me to talk here. And I prepared some slides to talk about Ebola, and feel free to interrupt and ask me questions. I work at the University of Pennsylvania. I am not an expert in Ebola by any means. I am an infectious disease doctor. I take care of patients with infectious diseases, and we are getting prepared to take care of patients with Ebola if that happens at the hospital of the University of Pennsylvania. Most of my life have been devoted to take care of patients with HIV and other infectious diseases. So I hope they don't be very loud, but I hope I can talk from there because it's difficult to talk from here. I hope you can hear me in the back. If not, I will talk louder. Can you put the next slide? So I want to thank you, PJ Brennan and Neil Fishman, who are leading the effort at the University of Pennsylvania at the hospital. I borrow many slides from them, and I have a disclaimer. I am not an expert in Ebola. I don't think many people are. People that are experts in Ebola are working now in Africa. And I am just an infectious disease doctor. Next slide. So I'm going to talk about the virus, the history of Ebola outbreaks. There was a question about that before. What is happening in the current outbreak? How does Ebola present clinically? What do we do to diagnose cases of Ebola in this country now? What is the risk of transmission? What we are doing at Penn about Ebola, and what you can do about Ebola here and in your home country. Next slide. So the first thing that I want to talk is about, we need to put this in perspective. Everybody seems to be extremely worried about Ebola. Ebola is a terrible disease, it's killed many people, but we need to worry about other things too. Obesity kills 300,000 people a year in the US, tobacco kills 450,000 a year, more than 1,000 a day. There has been one death of Ebola in this country, 10,000 deaths of Ebola probably in West Africa. We need to put these things into perspective. It's not to say that Ebola is not a terrible disease, it is, but there are many other things that we have to pay attention to. Next slide. So the virus, I'm going to be quickly about these more science things. It belongs to a family called filovirus. And why is that name? Because it has this filamentous shape when you look under the microscope. It has this shape, elongated shape, and that's the family that the scientists put this virus in because of that. It's an RNA virus. The genetic information is carried in DNA and RNA. There are viruses that come in both flavors. There are DNA viruses and RNA virus. This is an RNA virus. They tend to replicate faster. They tend to have more mutations and adapt faster to the host. And the problem with Ebola is that we don't have a treatment now or an effective vaccine. There has been around 20 outbreaks of Ebola virus so far since 1976, which was the first outbreak. And another virus that belongs to the same family, called Marburg virus, have been around 20 outbreaks since then. And the epidemic that is happening now is one of the 5 Ebola viruses that are out there. It's called Ebola Zaire, which is the first virus that produced the first outbreak in the Democratic Republic of Congo in 1976. And as you can see, you cannot see very well, but most of the outbreaks of Ebola have happened in Equatorial Africa, and this outbreak has happened here in West Africa, and is the first time, second time, there was a single case of somebody in Ivory Coast many years ago, but it's the first time that it has come out of West Africa, of Central Africa. Next slide. This is what we know about the virus. The virus is a zoonosis. It lives in the host, which we don't know for sure, but we think the definitive host is bats. We don't know the species of bats, but we think the virus lives in bats. And it doesn't do anything to them. It has been living with them for probably millions of years, and the virus replicates in bats, and it's happy about it, the bats are happy about it, and it keeps replicating the virus. The problem is when it goes outside. It's called a spillover. We call it a spillover is when it changes the species where the virus lives naturally, and then it infects other species. And infects primates like gorillas, and infects some deer in West Africa, and that's what we call a spillover. And in the regular host, it doesn't do anything. In in one of these spillovers, it can be very pathogenic and produces disease. So in gorillas, it has killed many, many gorillas in some of the sanctuaries in these countries, and it has killed a lot, can kill a lot of deer. We don't see that, because when a gorilla dies in the forest, it's very quickly, it gets decomposed, and we don't see all the death that is happening in other animals. Humans get infected when they get in contact with animals that are sick or bad or bats. So humans get infected accidentally. It's not the regular host. And then they can transmit it between them. And that's what's happening in West Africa right now. So virus doesn't do anything in the regular host. It spills over to other species, and that's when humans get infected. When people eat bushmeat, when people get in contact with feces from the bats, because there's some of these bats that eat fruit. And if you eat the fruit that has been contaminated with the stool from the bats, maybe you can get infection that way. We know a little bit about this cycle. We don't know everything yet. Next slide. These are the history of the epidemic so far. And this is also to answer some of the questions. Why we have not devoted so many resources. The problem with Ebola is that you have very aggressive outbreaks that happen in a village or and are linked to a specific case of exposure to an animal, and then they disappear very quickly. And then they don't appear for many years. So the first outbreak happened in 1976 in Zaire. It killed 431 people, but then it disappeared very quickly. And there has been many outbreaks over the years in different parts of Africa, but they disappear quickly from the community. And now the outbreak in 2014 is the worst, the largest outbreak. But as you can see, if you look at these graphics that come from the New York Times, the circle that is more orange is the proportion of deaths. So the first outbreak, almost everybody that got the disease died. In this outbreak, because we know better, is less lethal than the first outbreak. It's the same virus, Ebola Zaire, but now we have learned how to treat the infection better, and that's why there is a little bit less mortality than it used to be in the first outbreak. So this is the worst outbreak so far that has happened around the 20 outbreaks that have happened so far of Ebola. Next slide. So what is happening? The largest outbreak started probably in December, and of last year there has been rapid progression, and as of today, well, this is from November 14, there has been 6,000 cases in Liberia, 2,800 deaths. In Guinea, there has been Guinea-Conakry, there has been 1,900 cases, 1,100 deaths. In Sierra Leone, 5,000 cases, and 1,000 deaths. Next slide. This is by districts or province. I don't know how the structure goes there. Where it has countries that have been more affected by this epidemic: Liberia, Sierra Leone, and Guinea, particularly in the east of Guinea-Conakry. Next slide. This is the number of cases in a table. There has been some cases in Mali. There are 3 or 4 more cases in Mali as of yesterday, I think. And in the US, there has been 4 cases in Spain, which I am originally from. We had 2 cases of missionaries that were repatriated to Spain, and 1 nurse that acquired the infection while she was taking care of those priests. Next case, next slide. What is happening now in Liberia? So this is data from October 28, and this is the number of cases by week. So each one of these bars represents the number of cases at the end of the week that were reported to the WHO. And in the week that ended on October 28, so 2 weeks ago, there were 1,600 cases, new cases in Liberia, 500 cases in Sierra Leone, 100 cases in New Guinea. And the following week, and this is some of the good news, next slide, there were less cases, 211, a total of 500 cases, 200 in Liberia, a little bit less cases in Sierra Leone, and 99 cases in Guinea. So it seems that the epidemic has peaked, but it's not the time for complacency. The president of Liberia, I think yesterday or the day before yesterday, said that lower the level of emergency. There's still a lot of cases, there's still lots of things to do. But the last data seems that the epidemic has already peaked and is going down. We'll see what happens next week. Okay? This is as of 1 week ago. Next slide. These are the cases outside West Africa. As you can see, it has happened. There has been several cases in the US. Most of them have survived. There was a death in Dallas from a Liberian citizen that came to the US, went to the hospital, was sent home, and then came back to the hospital. And then there has been 2 nurses from that particular case that were taking care of that patient that became infected. And then some people, healthcare workers that were working in West Africa and were repatriated to the United States. And the New York doctor that was working in West Africa and came back. But there has been cases in Europe, very similar to the US cases, people that were working in West Africa. Next slide. So these projections were done a few months ago, and they are probably wrong, because I think people thought that they were going to be in January if we didn't do anything, in January 20 of 2015, there would be around 500,000 cases in Liberia. It doesn't look, thank God, that that's going to be the case, and I think we're going to see because there has been a big reaction both from the governments in Europe and in the United States, in Africa, and also the local community in Sierra Leone, Liberia, and Guinea that are helping to curtail the epidemic. Next slide. So this is what happened with Ebola in the US. 2 cases, the recently arrived Liberian man in Dallas, and a physician who was working for Doctors Without Borders in Guinea. 2 nurses that became infected after taking care of Mr. Duncan. 5 additional cases that were brought into the US of people that were working in West Africa. So a total of 9 cases here in the US, only 1 death. It means that mortality is very different in the developed world, where you have access to specialized facilities, when you compare the mortality in West Africa, where hospitals are probably not that ready, where the mortality is around 60%. So here, the mortality is around 10%, in West Africa is around 50% right now. Next slide. So how does Ebola present? And the problem with Ebola is that the symptoms happens around 8 to 10 days after exposure. The range is 2 to 21 days. This is why we have these quarantines of 21 days, because most people have the disease within 21 days of being exposed. And at the beginning, it looks like the flu. It doesn't look that bad. It looks fever, chills, muscle aches, malaise, you feel not very hungry. It's like the flu at the beginning. And then after 5 days of not feeling very well, you start having diarrhea, nausea, vomiting, and sometimes abdominal pain. And then you can have other symptoms when the viruses start spreading, like includes headache, conjunctivitis, hiccups, rash, and confusion seizures. And people usually die or have problems because of the diarrhea. They lose so much fluid that then they become severely dehydrated, and then when you are very dehydrated, your kidneys stop working, your lungs start not working very well, and then that's why you die when you get ill. But at the beginning, the symptoms are not that specific. You are not contagious when you are incubating the infection. You are only contagious when you are sick. That's an important thing to remember and to learn. Okay? And people from Liberia, people from West Africa, people from the US can have many other things that are not Ebola that presents with fever, chills, and this way. You can have typhoid fever, other infections like Lassa, you can have the flu, you can have malaria. One of the cases that I saw at Penn was somebody that came from West Africa with fever, malaise, not feeling very well, and the patient had malaria. Okay, it's important that we know about these symptoms, because the symptoms are not very specific, and we need to think of other things that are much more common than Ebola. Next slide. This is just a picture, complicated picture, but it shows In red, symptoms of Ebola, and in blue, symptoms of things that are not Ebola. And as you can see, diarrhea, asthenia, headache, anorexia, nausea, vomiting, they look awfully similar. This looks a lot like the flu, and then after a few days you start having the diarrhea. Next slide. So the question that the CDC and we as doctors are worrying about is, when we see a patient that has these symptoms, we need to, has been traveling recently to Liberia, Sierra Leone, or Guinea, the question is going to be, is it flu or Ebola? We don't know. Unless you test, you cannot know just by listening. But in this poster, you can see differences. And the main difference is that in general, when you have Ebola, you have more symptoms associated with the GI tract, more diarrhea, more nausea and vomiting than when you have the flu. Flu starts with the rhinorrhea, the nasal congestion. But at the beginning, both things can be similar. And that is also part of the problem when we're getting ready to, in the US, to take care of these patients. Next slide. How do we diagnose Ebola? And there was a question about this. We look at two things. We look at the virus in the blood, and the virus in the blood is very high at the beginning of the infection. And then we look at the response of the body to the virus. We look at antibodies against the virus. And those becomes positive later on in the disease. You need, your body, your immune system needs time to develop a response against Ebola. So if somebody comes with symptoms in the ER, to the hospital, we will do a test that will look at the virus, and then later on, we can confirm that by looking at the immunological response. But it doesn't make sense to test anybody that has not been traveling to Africa, because you're not going to see the virus at the beginning. Many people have asked me and other providers, can I get a test to rule out Ebola? Well, no, if you don't have symptoms, you don't have Ebola, period. Okay? Next. How is transmitted? It's transmitted by direct physical contact with blood or other body fluids of somebody that has Ebola. And that's why the problem is a lot in the hospitals and a lot of people preparing the body of the dead. The transmission only happens when patients have symptoms. The transmission, in spite of all the panic, is relatively inefficient. And Ebola is not transmitted by causal contact, water, or sharing the airspace. Some data, okay? In the outbreak in 1995, in the Democratic Republic of Congo, 173 household contacts of 27 patients only had 16% transmission. Mr. Duncan, you remember Mr. Duncan, was in a house with his girlfriend and several other people. None of them got Ebola, and they were living together. They had, she was his girlfriend, so you're not going to the test. Okay? So it's not that easy to transmit. Next slide. So transmission, facts about Ebola in the US. You don't get Ebola through the air. Okay? This is not like the flu that you can get it through the air, or TB. You cannot get Ebola through the air. You cannot get Ebola through water. You cannot get Ebola through food that has been grown and legally purchased in the US. You can only get Ebola from touching the blood or body fluids of a person who is sick or has died from Ebola, touching contaminated objects like needles, and touching infected fruit bats or primates. So bushmeat or having contact with the blood, with the bats. Next slide. So, conclusions. Ebola virus is difficult to transmit. You have to have contact with blood or other body fluids. It's not transmitted by causal contact. You can safely take care of patients with Ebola in the developing countries and also in the developing world right now, because there has been a lot of hospitals put in place and care facilities in Liberia, Sierra Leone, and Guinea. Mortality is much lower than was in countries, And planning and teamwork is essential to improving outcomes, both of patients and the healthcare providers. Next slide. What are we doing at Penn? Next slide. So at the beginning, the hospital got together. I mean, we were very confused. And then the hospital decided that all the providers had to be volunteers, that this cannot be an imposition of people. And the response was unbelievable, incredible. So more than 70 physicians volunteered to take care of patients with Ebola. We had a case with Ebola at 10. They come from infectious diseases, from critical care, from hospitalists. Nurses' response was incredible. Nurses are the people that are highest risk because they spend a lot of time in the room with a patient with Ebola. The response is incredible. If you want something organized quickly, talk with a nurse. Never with a doctor. Talk with a nurse. Okay? They organize the classes to teach us how to use the personal protective equipment. They organize the shifts in the ICU. They organize everything. Even the plumbers volunteer because you have to change the plumbing system in the rooms because you need to put bleach to prevent the pool of the water into the water supply. We had to change everything in the hospital, the way we work because of this epidemic, and it has bring the hospital together, and the response has been I am really impressed and amazed of how the hospital has responded to this emergency. Next slide. So things that we are part of a network of hospitals that volunteer or agree to take care of patients with Ebola, including Jefferson and CHOP. Philadelphia Department of Health asked our hospital to receive travelers if they are coming from affected areas who report illness to the Department of Health within 21 days of travel. So the Department of Health told you that they are monitoring people that are coming from Liberia or from any of the affected countries for 21 days. If any of them develop symptoms that they need evaluation, they will come to one of these hospitals, and we are one of them. And the CDC also identified one hospital to transfer people if they were sick when they were taking care of patients in West Africa. Next slide. So we created a team. It's led by PJ Brennan, who is the CMO of the hospital, and Neil Fishman, who's an infectious disease doctor, who I borrowed many slides from him. Next slide. And everybody in the hospital is getting involved. It's not only physicians, nurses, custodians, the security guard, everybody in the hospital is being affected by this. Next slide. We changed the way we created an isolation unit in the ER, where if somebody presents within 21 days of coming from West Africa with symptoms and needs evaluation, that patient is put in this room. It's a Spartan room, but it's a good room. And then we modify one of the rooms in the ER that has a room that allows changing of the personal protective equipment before going into that room. Next slide. This is in the ER. And then we blocked 5 rooms in one of the ICUs of the hospital, and we created a special treatment unit in that place with an entrance from the outside. And we basically created a unit where we can take care of up to 2 patients with Ebola virus disease properly, making sure that we take very good care of the patients and also that we protect the healthcare personnel that is taking care of the patients. Next slide. And we have gone to these trainings to put the personal protective equipment, and there is what we call the dry gear. This is for patients that are under suspicion that might have Ebola, that need to be evaluated. This is how I dress if I had to see one patient. And this is for nurses that are personally taking care of the patients in the room if they have Ebola. And we have to be trained. It takes around, the problem is not to get into these things. The problem is to get out of these things. So as you can imagine, people sweat a lot inside these plastic bags. And you have been taking care of a patient with Ebola, you might have blood or stool because there is a lot of diarrhea on the equipment, and the the thing that you want is to get out of that thing, of the whole equipment, and you have to do it very slowly in a process. You have to be clean with bleach, and then it's a ritual. It takes around 20 minutes to take this out. So you have to put soft music and follow the instructions. You follow the instructions, because if you get anxious, next slide. And this is transport. So if there is somebody with symptoms of Ebola that goes to an emergency room and needs to be transported, because we are the hospital that will receive these patients, there is a special unit that will take care of that patient from another ER and bring it to the University of Pennsylvania. And this is a picture of the unit. And there are processes of how to disinfect the unit and everything. Next slide. What can you do? I told you what we have been doing at Penn, and now what can you do if you live here? You have to educate about your community about Ebola. Avoid spreading hysteria. There is a lot of people saying things of Ebola that are not correct, and even governors that are saying things that they shouldn't be saying. Follow the recommendations of the Pennsylvania Health Department, and this is very important. Make sure that you promote flu vaccination in your community, because the symptoms are so similar. If you get vaccinated against the flu, you decrease, it's not a perfect vaccine, but you decrease your chances of getting the flu, and that will help the doctors if you present with symptoms. It will decrease the likelihood that you're going to present in an emergency room with a flu, which can be confusing with Ebola at the beginning. And if you visit your home country, I know that many of you have canceled trips to your home country, but protect yourself, protect your family, protect your community. You have to clean your hands often. You have to cook the food well. If you get, or if you know of somebody that has Ebola, quickly call the transportation and get them to a hospital where they can provide care. The sooner you are taken care in a hospital, the more likely you're going to survive Ebola. What happened before is that because everybody with Ebola was dying, people felt that if they go to the hospital, basically they lock you in a room and they don't do anything for you. So you will wait and wait and wait before going to the hospital, and that's when the mortality goes up. The sooner you show up in a hospital, the more likely you're going to survive. And that's a lesson that we need to learn. And then, of course, the things that you don't have to do, and eat bushmeat. And another thing that you cannot do is, although human nature, you want to take care of the sick. If you have a family member or somebody in your home country that is sick with Ebola, it's not a good idea to take care of them. As against nature that goes. You have to take that patient to a hospital and let people that are protecting themselves with adequate equipment to take care of that person. And those are the main important messages if you go to your home country. If you come from your home country here and you're within 21 days and you start having fevers, don't ignore it. Okay? It's not, you just have to call the health department, and the health department will take you to a hospital where we can evaluate you, send those tests, and decide if you have Ebola or not. Next slide, and I think that's all. Experimental therapies. We're trying many things. I've been trying in the developing world, in Liberia and in Sierra Leone, and we're trying vaccines, convalescent human serum, so survivors of Ebola, they have antibodies in their blood that can be used for treatment. We have not proved that that's effective, but it has been used in several cases. There are antiviral medications that have been tested. You might have heard about monoclonal antibodies called CMAP, one of the first antibodies that was tested in patients with Ebola. And we're trying to develop vaccines. At Penn, we might be doing a phase 1 study with a vaccine trial. We still don't know if we're going to have it or not. If we have it, I might talk with you about that vaccine study. But it's just what we call a phase 1 to prove that you can make antibodies against the vaccine, and that might be useful in preventing the infection if you're exposed to Ebola. But we don't have that open or approved yet, so I'm not going to talk about it. And that's all I wanted to say. Thank you very much. Sorry.